Okay, so I'm going to speak today about the isolation of pulmonary veins by electroporation. This will be a catheter design comparison. So a little bit of the agenda here, I'll tell you a little bit about me, set the objectives for my talk, describe the disease that we're targeting, and then describe the designs that we are going to be comparing. First of all, we're going to test some simple geometry models. It's faster and try to see what are the most impactful design variables. And then we'll test some more complex anatomical models. A little bit about me. I'm an electrical and biomedical engineer and biophysicist. Experience in technical and scientific roles in implantable external and catheter therapies for arrhythmia, heart failure, and neuromodulation. I worked at Guidant, Boston Scientific, Abbott, St. Jude Medical, Physio-Control, and Cardionomic. And you can contact me through LinkedIn. My disclosures, I'm currently consulting for Cardionomic and Boston Scientific, but not in the area of today's presentation. Currently discussing a consulting role with Cardium, and I have patents pending on some of the concepts being presented today. Okay, so the goal will be to compare major catheter design alternatives, electrical and mechanical, using modeling with COMSOL. And as I said before, two main parts, simple models, and then more complex anatomy models. So the disease we are talking about is atrial fibrillation, and its treatment is pulmonary vein isolation. It is an arrhythmia of the upper chambers of the heart, the atria. It is often triggered by abnormal activity in the pulmonary veins. You can see my mouse. This is these are the pulmonary veins that return from the lung into the left atrium right here. And pulmonary vein isolation, PVI, isolates or ablates these veins by causing necrosis of the tissue. Typical technologies are RF energy, radiofrequency energy, or cryo, delivered as you see here with a cryo balloon. And then the last 10 years or so, a new technology has been coming forth, and that's electroporation, which is the one that I'm going to be focusing on today. It uses short pulses of high voltage to make cell membranes permeable. It causes irreversible damage to the cells if the voltage is high enough, and the necrosis is not caused by thermal means like in radiofrequency energy or cryoablation. It is a tissue selective energy in the sense that it will cause lesions, therapeutic lesions to the cardiac myocytes, but will spare the nerves and the esophagus that are in the area. Now, I will raise some questions about this a little later. We'll come back to that. Here are the three designs to compare. So we have a balloon with electrodes on it. We have a splined system with flexible circuits and electrodes on it. And we have a typical conventional ring electrode catheter. So let's dive into the simple geometry models. What was done, first of all, is to create a spherical geometry. You have a layer of blood, then you have the layer of myocardium, a pericardial fluid, and a pericardial fluid layer, and then on top of that, a lung and fat tissue. So a very simplified way to model this anatomy. We have a target centered on the central electrode here. It's 5 millimeters wide, and it's what we're trying to do, and it's as high as the myocardium, as you see here. And what we're trying to do is measure how much of that target is filled, so to speak, with 600 volts per centimeter of magnitude electric field, which is a requirement of electroporation. We have to choose the thickness of the left atrial wall. There is good data on this. 2.5 millimeters was chosen. If you wanted to be really inclusive of everyone, you probably should go 2 standard deviations above this, so maybe 3, 4, 5 millimeters thick, pretty thick atrium in that case. But for the moment, we chose 2.5 millimeters, and we'll keep this in mind. We'll come back to this. Now, the motivation to study the balloon membrane as a variable is that it prevents current from flowing backwards, and so it should improve efficiency. So again, here are the 3 designs to compare in their simplified implementations. The spline system, a tighter spline with 4.2 millimeters with no balloon. Hopefully, you know, if the splines are close together enough, then that does the same thing as the balloon membrane, so that's the motivation there. And then the typical ring electrode catheter, and it's all been flattened out. It's not circumferential. We'll do that later with the true anatomy. Here are all the combinations that were tested. So the rows here are the energy delivery methods, and the columns are the different devices that were tested. Unipolar, of course, refers to current flowing from one electrode here to a patch electrode in the back of the patient. Bipolar, from one electrode to the next. Multi-unipolar means electrodes all energized simultaneously to the patch in the back of the patient. And then we have the interlace system, which is also used in current RF systems, in which the polarity is alternated among the electrodes. Okay. I was very interested in modeling the vicinity of the membrane and electrode and the polyimide of flex circuits, because this is going to be an area of very high voltages. So a lot of care with filleting this appropriately and a high density. But as a first pass, it's very convenient to use COMSOL's contact impedance boundary condition. It has some assumptions on normality of current, but it works pretty nicely because we're talking about a 20 micron, maybe 5 micron balloon membrane thickness. In terms of outcomes, we're looking at an efficacy outcome is defined as the percent of the target volume. Again, look at the target over here on the right. The target is that box, 5 millimeters wide, 2.5 millimeters tall, which is the thickness of the myocardium. As you can see it down here in this one simulation. We want to fill that, and we want to measure the percentage of that volume that has more than 600 volts centimeter as a function of current. Okay, so that's the efficacy outcome, the metric that we're going to use for comparison. In terms of safety, we want to look at the current density to achieve 90% target. And I'll explain this a little bit more in the next slide. We're going to also look at the energy delivered in the blood. So the blood, again, is this space. Again, this in the middle here is the myocardium. This is lung and fat, and this is the blood inside the left atrium. So we want to measure this energy here and use it. We want to minimize that as a measure of safety. And then energy delivered to extracardiac tissue is the energy delivered over here. That would be where the esophagus or the aorta would be located. In any case, we're only looking at one target, but you can imagine if we're stimulating on each electrode in turn, we would create an isolation barrier here that is 5 millimeters wide. So it's enough for now to just look at one target right here, one box volume there. Now, why should we be concerned with current density? Now, current density is defined as current divided by the area of the electrode. Well, that's the prime variable that drives the electrochemical reactions at the electrolyte interface. And very good work here from the group in the University of Ljubljana. Anyone can verify this on the bench. If you use high enough voltage on electrodes, they will start to produce gas as a result of electrolysis. And in fact, this is what happens in electroporation. This was a case shown at the Atrial Fibrillation Symposium just this last February. The moment that electroporation is turned on, you have a shower of bubbles being released in the left atrium. This is intracardiac echo. These are things that have been studied on the bench and in animals to try to show that they're relatively benign. In any case, you do want to minimize the amount that this is happening. You don't want these bubbles embolizing. Anything you do here in the left atrium is going to go into the left ventricle and immediately up to the brain. And in fact, there have been reports of lesions in the brain caused after PVI by electroporation, such as this one. They may or may not resolve, they may or may not be asymptomatic, but I think we can agree that we don't want any bubbles or metal released into the body if we can help it. In terms of methods, of course, if we're working with electroporation, we have to use a nonlinear model of conductivity. And COMSOL is very convenient for this because all you have to do is define an analytical function that looks like this over here, which indicates how the conductivity changes as a function of the electrical field. And then the other thing you have to be careful with tissue properties is not to go to popular databases and just choose the value that's there. It's always good to take some time and investigate where those values came from. This is the Gabriel data that is very popular for myocardium, and you can see what they did was they collected a number of data from a number of studies, and then they parametrized that with a data fit. When they did that, they went from strong data at 0.48 was parameterized to 0.14, 0.18. So I like to look at whether the data was in vivo, was it from an autopsy, how fresh was it measured with a bipolar system or a tetrapolar system, which is more robust and protects against polarization errors. Here, for example, is more recent data that was used to as a source for myocardial conductivity data. So just a word of caution there. Okay, so let's look at the results of the simple geometry. So we did a lot of combinations. There's a lot of data here. I'm not going to focus on all of it, but by and large, you can see the solid lines, which are the balloon with membrane, are perform better than devices that don't have a membrane or insulation in the back. Those are the dashed lines. And here on the x-axis, you have the current, and on the y-axis is the percent of that target I showed you. We want to increase current and fill that to nearly 100% in order to create the barrier. So generally, we can see that balloon catheters are perform better than splined or ringed ones. And then the interesting observation here is that the ringed catheter had the lowest efficacy. You really have to go very high in current before you are going to get to 90% or 100% transmural lesion. Among the splined catheters, those are without a balloon, the one that was tighter with 4.2 millimeter spacing had the highest performance. So let's just look at a subset in detail. And again, you can look at this later in the recording. There's a lot of data in that slide that I just showed you. But again, a unipolar balloon, one electrode at a time, had very good performance. Then can compare that to the splines at 4.2 millimeter, all fired at once. simultaneously in a one-shot manner. Then you have the interlaced splines in red, dashed red. That's an interlaced system. And then you have the interlaced ring, which again did not perform very well. Qualitatively, this is how things look. Unipolar balloon, 99.4 coverage of the target. And I'm going to show you little insets here for each of these. The top inset here is the endocardium, so that's this level down here, okay? So if I view it superiorly, I want to see how if there are any areas of poor coverage at this height. And then the pericardium, near the pericardial space, this is how it looks. And so you see 99.4, it's probably these little corners over here that are not fully ablated at 5 amps. All these I'm going to show you are at 5 amps. So here again, multi-unipolar splines, all energized simultaneously. You do have some current leak in between the splines, even though they're tight. You have a lot of energy into the lungs and fat and esophagus and aorta, modeled here. You can see where it's imperfectly covered. Here are the interlaced splines, spaced 6 millimeters apart. Nice way of, that's the beauty of the interlaced system, is that you contain the energy well within the myocardium. And then having the insulation on the back helps a lot as well. You see where it fails. You're at the top at the epicardium. And we have the interlaced ring catheter with a lot of energy being wasted in the blood and causing bubbles. Okay, so again, when we're looking at the weakness of this system, it's at the epicardium. And remember, I told you I chose 2.5 millimeters as the thickness of the epicardium. If we had gone to 4 millimeters, this would probably look even worse. So something to keep in mind. Now, in terms of the dielectric strength of the balloon membrane, when you're using very high voltages, one experiment that was done was to fill the balloon with dextrose instead of saline, which is commonly the conventional fluid to fill catheter balloons. And you can see that the requirement for dielectric strength is substantially reduced when you use a dextrose-filled balloon. So we're here on the y-axis, we have kilovolts per millimeter. You need the balloon membrane of 10 microns to withstand 25 kilovolts per millimeter if you're going to use saline. But you have to withstand a lot less if you fill it with dextrose. So that's an interesting secondary result here. So here, recapping the results, and let's move on. We have a lot of material to cover, so I'm going to go a little bit faster now. This is just a qualitative assessment of the current density, again, showing how nicely a balloon keeps the current away from the blood, whereas in this system down here, the ring catheter, there's a lot of energy and current going into the blood pool. I'm going to skip this one real quick. These are just the field lines of 2 of the systems that I showed. Now, in terms of safety, and this has to do with the choice of energy delivery configuration, the multi-unipolar, that is, all the electrodes energized simultaneously, quickly escalates in terms of the energy in the blood. This is current. This is energy for a 100 microsecond pulse. The interlaced ring also has a lot of energy in blood. But in terms of extracardiac tissue, the interlaced ring does very well, which is its main merit, but the penalty and efficacy is large. I did not bother with thermal simulations at this point because we're still talking of very low levels of energy given how short the pulses are, but it is something to explore later on. In terms of electrochemical safety, the current density to achieve 90% target You can see that the electrodes that are bare and exposed to the blood pool will have a lot of current density before you reach 90%. So we can expect a lot of irreversible reactions going on. Okay, let's look at the anatomical models. I can see that I have about 10 minutes. So here you can see that one of the first questions you have when we're working with anatomies is what point of the, what instant of the cardiac cycle should you choose to generate your anatomy. I'm pointing here to the left atrium. It changes significantly, you know, where you are in the cardiac cycle. These are the pulmonary, the left atrium right here, pulmonary vein right there. What moment have a 3D, the time that you're interested in, of course, such as you don't want to stimulate during the refractory period of the ventricles. This is how the left atrium looks like after it was imported into COMSOL. Very nice operation. The lung, very important for us to look at any damage in the lung or what the currents are doing in the lung. There are a lot of vessels, of course, going into the lung. That was something to mesh. And here's the final mesh, organs removed, and you can see there the pool in red. Coronary. Okay, so for the anatomy, for the complete anatomical models, I looked at here the row. These are the combinations. There's 3 rows, the same devices that we looked at before: balloons, splines, and ring catheter, and then 3 energy delivery methods: the multi-unipolar, the sequential unipolar, so you fire 1 electrode at a time, and then the interlaced. And there were 2 schemes for interlace. One that I call a wide sequential, which leaves an inactive electrode between the energized ones. And this is because you have a flexible, you have a lot more flexibility here that could allow shorting. Like, for example, these 2 right here are very close together and they're shorting, possibly, which doesn't happen with the rigid catheter because that's what it keeps the electrodes separate. So I wanted to try whether this would still give some benefits and allow good efficacy. This is how the sequential wide interlaced system works. It's 2 deliveries. You can see the scheme here. So the first delivery is on the top, then you shift it to the next set of electrodes as shown here. This is just to show the anatomy. I really like how this looks. Ended up looking the tight fit that was lateral ridge of the left atrium. The splines, similarly, shown here in cutaway. And the same with the ring catheter. They were all applied to exactly the same position, so as to make the comparison fair. The target was a 6 millimeter wide section of the posterior LA wall, as shown here. And again, the efficacy metric is the percent of this target that has more than 600 volts per centimeter as a function of current. Now, again, the safety question about electroporation being tissue selective. So should I care or should I not care about, you know, the electric fields that are being set up in the outside of the heart, since it's a selective energy? There have been reports of esophageal injury with electroporation. One of these was shown at the AF symposium here. This is an endoscopy view of the esophagus after electroporation PVI isolation. You can see the left atrium is here, the aorta is here, so the esophagus is in between 2 big blood pools, so current's going to be flowing through it. You know, that people have often noted that with external defibrillation, which also uses very high voltages, there are skin burns. It's always been called a burn. But I have worked with external defibrillation in benches, and you can apply a defibrillator to a series of resistors and touch them right after the pulse, 360 joules. And they get warm, but not as bad to cause this type of injury. So you have to wonder, is this an injury from a burn really, or from electroporation? And of course we can model this, and it's something that I'm working on right now. So anyway, this is why I'm putting a question mark on whether electroporation is truly tissue selective. I think there's still people working on this. And then this is, so I quantified the amount of involvement of the esophagus and the aorta. The lung was also looked at. It has been injured with external defibrillation. This is an example of the sequential unipolar delivery. And COMSOL makes it easy to join these solutions into one and then calculate the target efficiency. This shows how, as you increase current, you have more and more coverage as expected. And in the right, you have the ring catheter showing how a lot of current is required, because a lot of the current is going into the blood pool. So you need a lot, and you're also using the interlace system. Okay, we're going up to 10 amps here. So here are two of the strategies that we use qualitatively. I'm going to have to go faster here because the time is ending. You can enjoy this later at your leisure. Let me just try to get here to the main results. These are very similar to before, mainly telling that if you use a multi-unipolar arrangement, you are going to have a lot of energy dissipated extracardiac, outside the heart. And then the main results for efficacy, again, you can look at this later on the recording, but balloons perform better than catheters without a balloon. The ring catheter performed at the bottom of these. And then the sequential wide interlaced, this is in the same order that you see here, performed pretty well. So in summary, I've shown you simple geometry models to select candidate designs. I've shown detailed anatomical models for greater accuracy and detail. And then I've shown you how modeling can be powerful in designing for safety and efficacy. Thank you.